Welcome back to Heart About Lupus, where we discuss everything about lupus. I'm Susie Eagles-Fright from Lupus South Africa and Andrea's Gift. Today we are discussing lupus and overlap diseases, means the diseases that can overlap with your lupus. And they are rheumatoid arthritis, Sjögren's, Raynaud's, Scleroderma, mixed connective tissue disease or MCTD, and antiphospholipid syndrome or APS. Just a note, I have had 2 strokes, so please just bear with me if I do struggle with pronunciation. So get a cup of nice hot coffee or tea, put your earphones in, sit in a relaxing chair, and let the two of us discuss lupus. Several autoimmune, rheumatic, and connective tissue diseases that manifest and behave in the same ways as lupus are considered lupus overlap diseases. So they behave in the same ways. However, there is a lack of agreement within the medical and lupus communities on just one definitive, inclusive list of these conditions. For this podcast, we have decided to focus on the most commonly reported conditions, which include rheumatoid arthritis, Sjögren's, Raynaud's, Scleroderma, mixed connective tissue disease, and antiphospholipid syndrome. In a 2015 Lupus Science and Medicine article, it was found that up to 38% of individuals with SLE may have an overlap diseases. Now, in the 18 years I have been doing this, I must tell you that I think that percentage is higher. Just like with many other health conditions, including lupus, the degree of which an individual experiences any overlap diseases can come and go over time and may even go into remission. For example, with me, I have rheumatoid arthritis, I have Sjögren's, I have Raynaud's, I have mixed connective tissue disease and antiphospholipid syndrome. I don't have Scleroderma yet, never. And I must tell you that the antiphospholipid syndrome is currently in remission. So it does happen that some of these diseases go into remission. Individuals may also develop an overlap syndrome, which is a bit different from having an overlap disease. In an overlap syndrome, the individual has 2 or more connective tissue diseases that usually occur at the same time. For example, an individual who has lupus and Sjögren's, which is another connective tissue disorder disease, has overlap syndrome. But if another individual has lupus and Raynaud's, which is not a mixed connective tissue disease, and no other conditions, they have overlap disease. Yes, with lupus and overlap diseases, things get very complicated. Unfortunately, it's not uncommon for someone with lupus to face one or more of these conditions. So, it's important to be as informed as possible in order to maintain an active role in the management of your healthcare and to be empowered as a self-advocate. Take responsibility for your care. Take the time to learn about different overlap conditions, including overlap syndrome itself and pay close attention to the changes in your symptoms and overall health. That way, you can effectively communicate with your doctor. If you only have a certain overlap disease, please forward this podcast to the necessary part. You don't have to listen to all of it. If you haven't got, for example, Raynaud's or Sjögren's, just go past that. Here is a brief overview of the most commonly reported overlap diseases. So it's a brief overview, but I have included extra symptoms to be sure which one is which. And even if you do which one is which, you still get confused. Rheumatoid arthritis. RA is an autoimmune disease and a connective tissue disease. And the symptoms are tender, warm, swollen joints. Joint stiffness that is usually worse in the mornings or after inactivity. If you sit on the couch for a while, you'll have stiff joints. Fatigue, fever, and loss of appetite. Early rheumatoid arthritis tends to affect your smaller joints first, particularly the joints that attach your fingers and your hands and your toes to your feet. As the disease progresses, symptoms often spread to the wrist, knees, ankles, elbows, hips, and shoulders. And you will be able to distinguish which area is worse. My worst area is the shoulders, and it does give me a lot of problems. About 40% of people who have rheumatoid arthritis also experience signs and symptoms that don't involve the joints. Areas that may be affected include skin, eyes, lungs, heart, kidneys, salivary glands, nerve tissue, bone marrow, and blood vessels. Rheumatoid arthritis signs and symptoms may vary in severity and may even come and go. Periods of increased disease activity is also called a flare. Alternate with periods of relative remission when the swelling and the pain fade or disappear. Over time, rheumatoid arthritis can cause joints to deform and shift out of place. So if you look at some of our hands and fingers, it's deformed. Your fingers get skew and there's this whole little bone thing, all that. About 1 to 3% of the population has RA, primarily women. So more people have rheumatoid arthritis than people have lupus. The earlier RA is diagnosed and treated, the better the outcome. It is typically treated by a rheumatologist through the use of anti-rheumatic medications, which include methotrexate, hydroxychloroquine, and sulfasalazine. Exactly the same drugs we get treated in lupus. Each of these drugs can cause significant side effects, but each can also alleviate and even prevent joint damage. Low impact exercises may also help manage symptoms and increase the range of mobility as muscle strength increases. I must tell you that there's definitely truth in the fact that the joints do not deform if you are treated with the right medication, because none of my joints in my hands, which is the mostly affected, and my shoulders are deformed yet. And I truly believe it's because I am on these drugs. The next one is Sjögren's syndrome. Sjögren, Sjögren's. Sjögren's syndrome is autoimmune disorder and also a connective tissue disease that affect the entire body. The symptoms are Addition to extremely dry eyes and dry mouth, some people experience muscle pain and joint pain all over the body, similar to fibromyalgia, because it dries out the membranes, which limits your ability to move. An abnormal sense of taste. I must tell you, I have had lupus for 19 years. I've been involved in lupus research for a couple of years, and I've had the support organization for 18 years. And this is the first time that I've seen that Sjögren syndrome has an abnormal sense of taste. And I have been wondering for months now, I cannot drink coffee. It tastes awful to me. And when I saw this, that's, you're never too old to learn, and you never know too much about lupus. You can always learn more. Burning or redness in the eyes, or grittiness like sand. Currently, my Sjögren's disease is very active. And in the morning, when I wake up, my eyes are closed with these crushed little things that gone dry, and it feels like I have sands in my eye. So what I use the refresh, because there's nothing else you can do. And then blurry vision, difficulty chewing and swallowing or talking. So there's a difference in if you have you know, a heartburn disorder, if you have your esophagus that spasms and is thinner, because there's not enough saliva. That's what makes it difficulty swallowing, chewing, and talking. And it also creates a full feeling something is stuck in your esophagus. That's exactly Sjögren's, because there is not enough hydration. Dry, itchy skin, dry cough, enlarged salivary glands, fatigue, tooth decay and early tooth loss. This is a question that we get every day. Sjögren's causes tooth decay and early tooth loss. I have a full mouth of dentures. When they actually took the step and removed my teeth, it was so dry that you could pull it out easily, because I had to move everything and then put in the dentures. It was horrible, but my teeth were so lost, and I had so much tooth decay. Vaginal dryness in women is a huge problem, not only for your sexual health, but it seems to cause infection, because that vaginal fluid basically protects you from infections in the bladder or wherever. And when it's dry, not there, you easily get infections. And I'm sure all of you can link with that. Structures and systems such as the kidneys and gastrointestinal systems, blood vessels, and lungs, however, may be effective. Why? Because it all works on membranes and liquids. Similar to lupus, symptoms of Sjögren's can change throughout the life and sometimes go into remission. Sjögren's and SLE are closely related to each other and share many of the same features. In a 2010 study, researchers observed that approximately 14.5% of individuals with lupus have Sjögren's as a secondary condition. You first have lupus, and then you have Sjögren's, which the lupus is an overlap disease with lupus. And I believe that percentage now in 2023 is a lot higher. A rheumatologist may prescribe medication that target dry eyes and mouth, such as cyclosporin, ophthalmic emulsion for the eyes, and pilocarpine hydrochloride for the mouth. Immunosuppressants may also be prescribed, and many over-the-counter medication may help alleviate the pain, discomfort, and dryness. So it has the same medications as they prescribe for lupus. So later on in this podcast, we will be doing OTC medications that you can buy to help you with Sjögren's, Raynaud's, and all those other ones. So the next one is Raynaud's phenomenon. Raynaud's phenomenon causes a restriction in the small blood vessels of the extremities, which in turn reduces blood flow. Extremities is your fingers and your toes. And if you have a cold area or cold winter outside, that blood vessels are restricted and your hands and feet turn blue. When the extremities are subjected to cold, the blood vessels go into spasm, causing pain, numbness, and skin discoloration. I always couldn't understand why there is pain until I finally found out that it's the spasm in the blood vessels that causes the pain with Raynaud's. So the symptoms is cold finger and toes, or areas of skin that turn white, then blue, depending on your skin color. These color changes may be harder or easier to see. If you are white, you easily see the discoloration, where if you are black or colored, it's difficult to see. Numb, prickly feeling or stinging pain upon warming or stress relief. So it's that needles and pin prickly feeling if you get the blood flowing again. During an attack of Raynaud's, affected areas of the skin usually first turn pale. Next, they often change color and feel cold and numb. When the skin warms, the blood flow improves, the affected area may change color again, throb and tingle or swell. Raynaud's commonly affects fingers and toes, but it also can affect other areas of the body, such as nose, lips, ears, and even nipples. Stress and emotional duress can often trigger a Raynaud's attack. If untreated, skin ulcers may develop, or in worst case scenario, gangrene may develop. So that's why I always say, please don't play around with Raynaud's. It can cause gangrene, and then they have to remove the finger or the toe. So it's very important to treat your Raynaud's. And if it doesn't get better while treating it on at home, go to the doctor. They usually can prescribe vasodilators, which can help with the blood flow. If there's no underlying explanation for the symptoms, then the individual is considered to have primary Raynaud's, because it cannot be attributed to anything else. So if they don't have lupus, it is a primary Raynaud's. If an individual has an autoimmune disease and or another connective tissue disease, then the diagnosis is referred to as secondary Raynaud's. Now that's what we all have. More than likely, a rheumatologist will diagnose Raynaud's. There is no one drug to treat Raynaud's, although calcium channel blockers to dilate blood vessels or topical antibiotics to treat skin manifestations may be prescribed. Also, in recent times, doctors prescribe Viagra, which is a vasodilator, which means it dilates the blood vessels. It actually works very well for Raynaud's that is very severe. It sounds strange, but really it works. Additionally, with primary Raynaud's, a regular exercise regime that keeps the body active, blood flowing, and stress at bay, then the symptoms will reduce. Even with secondary Raynaud's, exercise will improve your stress level and also the blood flowing to extremities. The next one is Scleroderma. Scleroderma is really very unknown because there are not so many people get scleroderma. Scleroderma is often preceded by Raynaud's phenomenon. Symptoms of scleroderma include thickening and swelling of the fingers, pale fingers that may become numb, tingle when exposed to cold or stress, known as Raynaud's phenomenon, joint pain, shiny darker skin on large areas, which can cause problems with movement, limited mobility or immobile fingers, wrists, or elbows because of the thickening of skin. Systemic forms of scleroderma are associated with involvement of the internal organs, which may cause calcium bumps on your fingers or other bony areas such as your elbows and knees. I've seen calcium bumps on a lot of warriors' fingers, sores on your fingertips and knuckles, a grating noise when you try to move your inflamed joints and tissues, problems of the esophagus, which can lead to heartburn. You see, there's a lot of these connective tissue diseases that is involved and affecting your esophagus. So it's no wonder that warriors struggle with trouble with swallowing, etc. Scarring of the lungs, which can lead to shortness of breath, heart failure and abnormal heart rhythms, high blood pressure that affects the kidneys. Scleroderma is considered a connective tissue disease and an autoimmune rheumatic disease. If untreated, the skin can become tough and like leather due to the buildup of collagen, which it can even spread to the face. That's basically scleroderma in inverted commas, buildup of collagen and calcium. Tissue loss and discoloration may occur. A rheumatologist and a dermatologist can treat scleroderma. Often the rheumatologist sends you to a dermatologist. Treatment frequently includes immunosuppressants, anti-inflammatory medication, vasodilator therapy, or an antifibrotic medication that are used to reduce collagen production. So it's got more or less the same treatment as lupus, except for the vasodilator and then the fibrotic medications. The next one is mixed connective tissue disease, which is MCT. MCTD has symptoms of several connective tissue disorders such as lupus, scleroderma, and polymyositis. I have not included polymyositis as a connective disease because most of us experience it, and it's just an inflammatory rheumatic disease, and it can cause weakness in your muscles, and that is why you struggle with standing up and sitting down or climbing stairs. So you anyway going to have it if you have lupus. An individual may not experience the symptoms of multiple disorders concurrently, however, and instead they can occur in sequence over time. This makes MCTD difficult to diagnose. In the beginning stages, people with MCD have symptoms similar to those of other connective disorders like fatigue, muscle pain, joint pain, low-grade fever, and Raynaud's phenomenon. Less common early symptoms may include severe polymyositis, so that's severe anti-inflamed disease, often in your shoulders and upper arms. That's where I also get it. Acute intense arthritis, aseptic meningitis is inflammation of the brain and spinal cord and not caused by a bacteria or a virus. Doctors, my current neurologist expect that I have been struggling with that for some time. Myelitis is inflammation of the spinal cord. Maybe you knew of it, You didn't know it, but I'm sure you have had myelitis in at some or other point in your journey. Gangrene, that's death in decay of fingers and toes. High fever, abdominal pain, neuropathy, so that means the nerves, affecting the nerves, and hearing loss. The classic symptoms of MCD are Raynaud phenomenon, we've discussed that, swollen sausage-like fingers, sometimes temporary, but at other times progressing into sclerodactyly, thin fingers with hardened skin and limited movement, inflamed joint and muscles, pulmonary hypertension, that's when the high blood pressure in the blood vessels around the lungs. Several healthcare practitioners treat MCD, such as a general practitioners, internists, neurologists, cardiologists, nephrologists, rheumatologists, and dermatologists. So, general practitioner is your GP. Internist they usually work with chronic diseases, diabetes, and neurologist is brain. Cardiologist is heart. Nephrologist is kidney. Rheumatologist is rheumatic diseases, and dermatologist is skin diseases. Medication that can help manage MCD symptoms are similar to those that treat lupus. So a lot of the time, your doctors and healthcare practitioners, as they call them today, may not add extra treatment to your lupus treatment because you're already using anti-immunosuppressants and stuff that treat the other overlapping diseases. So they can't, prescribe anything else. So when it gets worse, they usually treat it with cortisone. They usually include corticosteroids, anti-malarial drugs, calcium channel blockers, hypertension medication, and immunosuppressants. So the only thing that differs is the calcium blockers and hypertension medication, which most of us that are older than 35 usually have. The next one is antiphospholipid syndrome. So before I read and discuss the explanation, always think of antiphospholipid syndrome as the blood clot syndrome. Antiphospholipid antibody syndrome, which is APS, is an autoimmune disease mostly affecting women between the ages of 30 and 40. In APS, abnormal proteins, APL, can cause the formation of clots in veins and arteries. Clots may cause miscarriages, harm to the fetus, lead to heart attacks, strokes, and pulmonary embolism. That's exactly what happened to me. I have had 2 miscarriages, and I've had strokes and pulmonary embolism, which is a blood clot in the lungs, and I didn't have a heart attack, but I do have heart problems. In severe cases, multiple organs may be damaged. About 40% of systemic lupus erythematosus (SLE) patients also test positive for antiphospholipid antibodies, but only a few develop clots. The symptoms include pain, swelling, and redness in the legs, swelling, redness, and tenderness along an affected vein, high temperatures above 38 degrees Celsius, recurrent miscarriage, premature births. So you can see there's a lot of the symptoms that are separate from lupus that you can know this is the APS that is currently more active than lupus or the other way around. A diagnosis of APS can usually be confirmed if you've had one or more confirmed blood clots, one or more unexplained late miscarriages at or after week 10 of pregnancy, one or more premature birth at or before 30 weeks of pregnancy. APS may not be detected until an individual has unexpected problems caused by blood loss, such as repeated miscarriages or a heart attack. In recent years, I must say they have started to connect the dots to APS earlier on if you're diagnosed with lupus, because I check for it immediately. So it's earlier noticed. To screen people, 3 blood tests are checked and at least one must be positive and confirmed twice, at least 3 months apart. So that means that the blood tests are taken 3 months apart, and twice of those third blood tests are positive. 2, sorry. Some people with these autoantibodies never develop clots. Risk factors for developing blood clots include high blood pressure, obesity, smoking. Arteriosclerosis occurs when plaque build up in the arteries, taking birth controls, or having an associated autoimmune disease like SLE. I have developed carotid arteriosstenosis, which is there's 2 main veins that lead to the brain, and plaque builds up in those veins. It's only in the start of it, but I have developed that, and I am not obese. All the things, boxes I tick, but I still got it. And it's because of the APS and lupus having it for so long. APS raises the risk for blood clots, so treatment aims to prevent clot-related events. In an acute event, initially intravenous blood thinners or subcutaneous blood thinners are followed by oral medications such as warfarin, which may prevent future clot. Aspirin may also prevent recurring clot events. So the intravenous blood thinners, they put the blood thinners in your drip, heparin, and the subcutaneous injection is when they inject you in your stomach. That's also done in the hospital usually. It's called Clexane. They put you on warfarin and then check your blood constantly to see at which level your warfarin is working the best, to make sure that you don't have clotting events. To help prevent miscarriages, women with APS may be advised to use heparin or low doses of aspirin, corticosteroids, or even intravenous immunoglobulin during their pregnancies. So yeah, that's quite a few medication that they use. And when I was diagnosed, all these things weren't used. It's too long ago. Individuals who take blood thinners long term must see their healthcare provider doctor regularly to monitor the drug. So they monitor your bloods on a continuous, basis. Lifestyle changes should be implemented to prevent clots, such as managing your weight, stop smoking, avoid estrogen therapy, which is hormonal therapies that they use for menopause, and then also birth controls. And the doctor usually, unless your doctor usually prescribes these medications, and in agreement with your rheumatologist. Now we are going to discuss overlap syndrome. An individual has an overlap syndrome when they have at least 2 connective tissue diseases at the same time. These diseases include SLE, RA, Sjögren's, systemic sclerosis, that means the hardening of tissue and skin, dermatomyositis, and polymyositis, that is inflammation disease in the skin, and polymyositis is all the muscles inside. It is also possible for an individual to have both an MCTD and an overlap syndrome. Unfortunately, there has been less research on overlap syndrome itself than each of the other individual connective tissue diseases. Researchers of postgraduate medical education and research acknowledge that there is a need for dedicated clinical trials in patients with overlap syndrome for better understanding of the natural history, outcome, and treatment strategy required for these syndromes as a whole. Researchers note that an individual typically experiences milder symptoms of each individual condition when they have overlap syndrome. There are little research done on overlap syndrome because doctors treat each individual connective tissue disease separately. But if, for example, you are on immunosuppression, they won't give you an immunosuppression for the Raynaud and the Scleroderma and everything. You have been treating correctly. The kind of overlap syndrome that involves both SLE and Sjögren's, for example, they have found that individuals experience less intense symptoms of SLE and a predominance of Sjögren's syndrome related features. So they are exactly just saying that if your Sjögren's is more active, your lupus is less, and the other way around, which I haven't found, but I could be an example that's not part of the general. Because we are all different, it's difficult to say which and when. Some cases of overlap syndrome are easier to diagnose than others because of the identification of specific antibodies. Yeah, and that is, they do antibody tests, and if it's there, they know that it is. Rheumatoid factor, as well as anti-Rho SSA and anti-L SSB, can be found when an individual has SLE and Sjögren's. So what they do is they test for the ANA, and that's positive. Then they test for rheumatoid factor and the anti-Rho and anti-L antibodies, and then anti-Smith antibodies for lupus. So when they test for Sjögren's, they usually do the RF, SSA, and SSB, and for lupus, they do the anti-Smith antibodies. It's very complicated, but if you know just at least which antibody is linked to which overlap syndrome, it makes a lot of sense. In some cases, like with RA and lupus, however, there is no specific antibody profile. You can't do an antibody and then distinguish between lupus and RA. With regards to RA and lupus, which is called lupus, there is some debate as to whether or not this is an example of an overlap syndrome. But if you think about it, overlap syndrome is two connective diseases, tissue diseases at the same time. Rheumatoid arthritis and lupus is both connective tissue diseases. So it is an overlap syndrome. On the other hand, arthritis and arthralgia are extremely common manifestations of SLE, occurring in up to 90% of individuals with lupus. Arthritis, but arthralgia is the inflammation and pain in one or more joints in the body. In conclusion, managing multiple illnesses in addition to lupus can seem overwhelming. Keeping track of all the symptoms an individual may experience, however, will help your doctor properly diagnose, treat, and manage any additional conditions that may arise early on. So a great idea, what I usually tell patients to do, is make a list of every single symptoms you are experiencing, because there might be something that the doctor hasn't tested for that can be Sjögren's or Raynaud's or Scleroderma, or polymyositis. So it's very important to do that in the beginning when you start with your rheumatologist, or at any point in time in your journey you see that there's more symptoms that you don't know about. Write it down. It will help your doctors tremendously. Understanding when symptoms seems outside of the norm of what an individual may typically experience can help in the early detection of overlap diseases, which in turn can help maintain optimum health. That concludes this podcast. Please review it on the platform you are listening on. Leave a comment below on the topics that you would like us to talk about. If you enjoyed this podcast, please hit the like button below, follow us on Facebook, Instagram, and TikTok, and subscribe to our YouTube channel. Andrea's Gift, Greens and Teen, Lupus South Africa, and Susie Eagles Flight.
I travel alone, fare though the places.
Thank you for listening, and remember, giving up is not an option. Bye.
Has flown. I travel alone.